Welcome, everyone. My name is Sally Williams. I'm the Workforce Center Director at the DFW Hospital Council Foundation, and we are hosting this virtual education series for nurse educators. We have sessions on October 15th, 22nd, and 29th. So we're pleased to welcome you to today's session. The topic for our session today is identifying and responding to victims of human trafficking in a clinical setting and the impact of the pandemic on domestic violence and human trafficking. So we have a couple of speakers and a panel that we have put together for you today. We'll get started here. A couple of housekeeping things we have to do. First of all, we'd like to thank our event planning committee, and you can see them listed here. They gave us a lot of insight and guidance in putting together this virtual series. A couple of things on evaluation. If you have any questions about the event, please go to the DFWHC Foundation website to educational events, and you'll find all the details for this particular event. For the CE evaluation, the link will be available on October 29th. So once we complete the whole series, you have to complete the evaluation no later than November the 13th. And then about a week or two after that, we will send you your certificate. There is a separate link for the Human Trafficking Credit Hour that you will receive once you complete the evaluation as well. And then we will also be posting after each session the session recordings and presentations, so you'll be able to access that information as well. But again, go to our website. It'll have everything you need on there in regards to the event. There are no conflict of interest with our speakers in the session today. And then questions. If there'll be a period after our first two speakers, after each of their presentations, where we'll have questions, and we ask that you post those in the question box. You'll see that in the panel on the right-hand side. Looks like the kind of the grayed out button that you see here in this particular slide. So please go ahead and post those as we go through the presentation, and then we will address those at the end of each presentation and the panel. So I would like to introduce our moderator for today's session. Dr. Perez is a Level 1 coordinator and clinical assistant professor with Baylor University Louise Harrington School of Nursing. She has her DNP and executive nursing leadership from the University of Nevada. She also has her MSN from University of Oklahoma and her BSN from TCU. She also has experience in the hospitals as a staff nurse, charge nurse, and a preceptor. So with that, I'm going to turn the session today over to Dr. Perez.
Very good. Thank you so much for that introduction, Sally. So I just want to thank everybody for attending. I will start out by just introducing our first speaker, which is Dr. Jessica Peck. Let's see. Dr. Jessica Peck is an expert pediatric nurse practitioner and anti-trafficking advocate who provides innovative, visionary, and award-winning leadership to develop and lead inclusive and diverse interprofessional teams to provide outcomes of high-quality health care. Dr. Peck is a recognized and published national expert about human trafficking. She served as founding chair of the Alliance for Children in Trafficking, a national campaign of the National Association of Pediatric Nurse Practitioners Partners for Vulnerable Youth, where she worked with other national organizations to equip healthcare professionals to combat human trafficking of children and advocates for other vulnerable youth populations. Dr. Peck worked with the Office of Trafficking in Persons to help create a set of core competencies for healthcare professionals caring for trafficked individuals. She serves as the lead medical consultant for Unbound Houston and helped create a statewide continuing education and pass legislation mandating CEs for all direct care providers in Texas. Dr. Peck is currently a professor of nursing at Baylor University Louise Harrington School of Nursing in Dallas, Texas. She holds active credentials as a pediatric nurse practitioner, a certified nurse educator, and a clinical nurse leader. Dr. Peck has been practicing as a pediatric nurse practitioner for more than nearly 20 years in primary care environments. She travels nationally to speak on the use of technology in nursing education and practice, including health impacts of social media use by teens. As both a nurse practitioner and a mother of 4 children, she has a special interest in educating and equipping families to promote positive physical, emotional, mental, social, and spiritual health. She is an accomplished author of clinical articles for peer-reviewed journals, a regular contributor for parenting magazines, and a frequent guest on radio and television to promote the health of children. Dr. Peck?
Thank you so much, Candace. I appreciate the invitation to be with you this morning, and I thank all of you for joining us to talk about this really, really important topic. So yes, I am coming to you today from Unbound Houston and from NAPNAP Partners for Vulnerable Youth. I wanted to provide a little clarity about the requirement from House Bill 2059 in Texas. We did pass that last year, and it was signed into law by Governor Abbott, where all direct care providers in Texas are required to take a 1-hour continuing education in the next renewal cycle of your license on human trafficking. And that education has to be approved by the Texas Health and Human Services Commission, and this education is approved for that. It was one of the first to come out to be approved. So afterward, just like Sally told you, you will get a link to get a special certificate to have that just in case you were to be audited by the Board of Nursing, and you can show that you are in compliance for that requirement for there. I want to talk a little bit about how I got involved in this. You know, I never intended to be an anti-trafficking advocate. I never saw my career going that way or my personal life going that way. But about 4 years ago now, I'm friends with one of our state senators and his wife, and she runs an anti-trafficking group. And I honestly thought she went to Honduras or South America somewhere is what my mind was thinking, and she helped victims of trafficking, and wasn't that just so wonderful? She's such a wonderful person. And she called me and asked me if I would help her to develop some continuing education for nurses about trafficking, and I told her, no way, I don't know anything about trafficking. You have the wrong person. And she said, no, you don't understand. We're trying to teach nurses about trafficking, but no nurses know anything about trafficking. So at that time, I kind of agreed as a process expert. You know, I don't know about trafficking, but I do know about educating nurses. So why don't I help you with the process and tell you what the curriculum requirements are and the process is, and you tell me the content, and we'll partner that way, and then you can have your education and I'll have helped you. But the more that I learned about trafficking, the more I recognized I was asking the wrong question. I asked her, how can I help you? But really the question should have been, how can I not help you? And learning about what nurses can do in particular to impact the global epidemic of human trafficking is really important. And even now, in the rise of disinformation and conspiracy theories and people who are very well-intentioned but perhaps not well-informed about how trafficking is, it does a disservice to victims that we serve. And so as nurses, we need to be, as the most trusted profession, we need to be leaders in providing evidence-based, really high-quality information. Next slide, Sally. So I'm going to go ahead and next, I'm going to give you some conflicts and some disclosures, basically, that this is a difficult subject to talk about. It is, we are going to talk about some issues of violence and sexual assault and sexual abuse, and that can be hard. And so if you need to walk away from your computer or pause this or come back to us, please feel free to do that. Sometimes I find nurses who have been victimized in the past, particularly, this can be difficult. And sometimes when I've spoken, nurses have recognized their own victimization when they didn't recognize that before. So I just wanted to give you that, that kind of warning. I also want to give you a disclosure on statistics. Statistics for labor and sex trafficking are in their infancy, and they should be viewed through a critical lens. As nurses, we are very highly trained professionally to in a scientific profession, so we know how to evaluate research. And there are a lot of very common statistics that are repeated in some anti-trafficking education I've seen and on the news media that really are not based in sound research methodology. And so it is up to us to really make sure that we are using the best statistics possible that are based on reliable and valid science. And so the statistics that I'm going to give you today, I'm giving you that disclaimer that is the best information that we have, but I'll walk you through kind of some of that information. One of the examples that's commonly repeated is that a human trafficking victim has an average life expectancy of 7 years. Well, if you kind of dig down and look for that, it came from an FBI report and one agent's kind of subjective opinion and some of the informal data that had been collected. So what we do know is that human trafficking survivors do have a decreased life expectancy, but we don't know exactly how much that is. So that would be one example. Another example would be human trafficking increasing around sporting events like the Super Bowl, which really has not been very well supported by the literature. But what we do know is anytime there's a large gathering of people, and primarily men who are buyers of sex trafficking, that there is potential for victimization. So just want to give you that disclaimer as we go. Next. The learning objectives will be, we're going to talk a little bit about the healthcare response. We're going to talk about trauma-informed care, best practices for what do you do should a victim come into your clinical environment. How do you equip your organization? And this is going to be really important, whether you are in a solo practice that's in primary care by yourself or whether you're in a healthcare institution with thousands of employees, everyone needs to be prepared. It's kind of like an active shooter scenario. That is something that we never want to see, but it's so high stakes and so such a dangerous, potentially dangerous thing with a lot of potential for harm. We all need to be prepared. So we'll talk about also the healthcare provider role in prevention, identification, referral, treatment, aftercare, and advocacy. Next. It's important to know that human trafficking, we've only had a federal definition of trafficking since 2000 in the Trafficking Victims Protection Act. And that is really not very long. And the important reason for that is because having a federal definition gives these victims different programs and access to different resources than they would if they were a victim of another crime or even prosecuted for another crime like prostitution. So it's basically, you can see the definition here, but it's basically the sale of another person's body or labor in exchange for something of value. Another really important thing to emphasize here before we go any further is a common misconception about human trafficking is that human trafficking is sex trafficking. And that is just not the case. There are many kinds of trafficking. There is organ trafficking, there is child soldiering, baby trafficking. But here in the United States, the two most common types are labor trafficking and sex trafficking. And one of the things I see as awareness of trafficking is increasing is nurses don't think about labor trafficking. And that is actually likely much more prevalent than sex trafficking, although sex trafficking is more salacious and gets more attention because in some ways it just seems more egregious in the public eye. But as nurses, I want you to know going forward, we will be talking about labor trafficking and sex trafficking, and I will give you some examples of both kinds of victims presenting for clinical care. Next is the action means purpose model. This is kind of a simplified version of the Trafficking Victims Protection Act. The action is what is done, the means is how it's done, and the purpose is why it's done. So any of these actions, you don't necessarily have to be involved in all of them, but even if you're involved in recruiting a victim, even if you're not actually selling them, if you're involved in recruiting them, or if you know they're a victim and you're involved in harboring them, or you just transport them knowing they're a victim, all of those things are criminal actions when it comes to trafficking. There is force, fraud, or coercion, but it's important to know this does not need to be present in sex trafficking of minors. Here's another example where it's very important for us as nurses to have appropriate terminology. There's no such thing as a child prostitute. Children cannot consent to commercial sex, and so they are victims of sexual abuse, period. We should not call them child prostitutes, and in fact, when I see news media stories on my local media, I will call them and politely and kindly, but emphatically inform them of such, that they shouldn't call these victims child prostitutes. What it does is it conveys to children that they are criminals, and that is just not the case. Now, the force, fraud, or coercion is not a necessary, it is a necessary element in labor trafficking of children because of the complexity of the law. Children are allowed to work in most states starting at 16 and sometimes younger, just depending, because you have babysitting or other things where they can do lawn services to work for money. And so there has to be some force, fraud, or coercion element there with the intersection with the laws. But basically, these actions are all crimes. Next. Another important differentiation is to know that there's a difference between human smuggling and human trafficking. So Sally, if you can go to the next slide. Yeah, there you go. So human smuggling is a crime against a country. It's where people are willingly, they pay for transport or someone pays for transport for them to illegally enter a country. Next. Trafficking is not smuggling though. Smuggling can lead to certain instances of trafficking. Go ahead and go to the next one, Sally. There you go. So sometimes victims of trafficking can initially come into the country by being smuggled in, and then they find themselves in economic distress, not knowing about the laws, maybe taken advantage of by someone who is waiting, because definitely there are people who take advantage of people who are smuggled into the country. Go ahead, next. But the difference between smuggling is that smuggling is a crime against a state, and it's transportation based, and it does require border crossing, and it is with consent of the person. Trafficking is a crime against the person, and it is exploitation based. No border crossing is required. It is also not required to cross state lines for human trafficking, although if they do, there are certain other criminal elements that make it easier to prosecute. And human trafficking is always without consent. Next. The most common types of human trafficking, as I said before, are sex trafficking and labor trafficking. Sex trafficking occurs through pornography. We are seeing some really shocking statistics that are coming from early research saying that, I won't give you a number, but that the majority of pornography is produced for victims of trafficking. And there's a misperception that pornography is consenting adults, and so why should we get involved in that? But many victims are forced or defrauded or coerced into producing pornography, and many are minor victims. And if you see websites like Pornhub, which is basically a social media site for pornography collectors, there are many underage victims there, but because of the laxity in proving that they're overage, that just continues in a prolific way. There's also forced prostitution, which happens in massage parlors. One of the most prominent national cases that happened was Robert Kraft down in Florida. And it was very interesting to watch the public dialogue on that. And I would look at the comments on the story, and people would say, this guy has so much money, what he does between consenting adults, if he wants to pay for this, and that's his business. But not recognizing that victims in massage parlors are often victims of both sex trafficking and labor trafficking. It happens also in nail salons. There is actually one massage parlor / nail salon in my community that is a trafficking hub. And it's not that we don't know about it, but these traffickers are very smart. And a lot of times they change their name for the doing business as. And having a raid there requires a warrant, and so they may change their name on a regular basis. So you have a warrant against one business, and they'll say, oh, nope, that's not this business, this is a new business. And so I'm not recommending this, but one thing that happened in our community was some moms got together on social media and decided to take turns posting outside of that place, of that establishment, and showing pictures of anybody that walked inside. Again, I'm not recommending that, but that is just an example of community action that has happened with people taking matters into their own hands. There are also online ads, Backpage.com. It is really shocking to know you could go to a website, which is like a Craigslist, Backpage.com. If it was up, I would tell you right now to go to it, Backpage.com. Seek the dating tab, the Dallas-Fort Worth tab, seeking women, and scroll down and tell me how long it would take you to see a minor in a sexually explicit position. And you would tell me about 15 seconds. You would then text that minor and they would show up at your house, at your hotel room, and provide sexual services. And you think, how can this be legal? Well, there was a section of the Communications Decency Act, which is the supreme irony there, because there's nothing decent about this, but it says that third parties cannot be, or companies cannot be liable for third party posting. So Backpage would say, oh, well, we know this is happening, but you can't hold us liable because, you know, they're posting this, and oh, we want to take it down. And then what they ended up doing was creating an emoji language where people would look for victims in emoji. So if you were looking for a minor girl victim, it might be a baby emoji with a pink bow. And then they outsourced all of the technical help to other countries. And so they would say, oh, they did this without our consent. And if you want us to help extradite these people from underdeveloped countries to come and prosecute them in the United States, then we'll do that. And actually who funded Backpage's legal defense would be the big tech giants, including Facebook and Google, who basically said it was an argument against free speech and that they really opposed that. But it was one mom, as many good stories of activism start, it was one mom who saw her daughter for sale on Backpage, who took it to one attorney in Oregon, who, if you want to watch the story about that, there's a great documentary called I Am Jane Doe. I Am Jane Doe. It's on Amazon Prime and Netflix. And you can watch that story of how they took down Backpage. And what resulted from that was Senator Rob Portman of Ohio sponsoring largely bipartisan legislation called the Fight Online Sex Trafficking Act, and it took Backpage down. So it still does happen, but the giant of those and the major mechanism for those is gone. There are also modeling agencies, escort services, strip clubs, and other various forms. Labor trafficking occurs in agricultural trafficking in Texas particularly. We have a lot of agricultural trafficking, and they're actually, if you follow me on social media, on Facebook or Twitter at Dr. Peck PMP, I posted a story recently about a trafficking worker during COVID in Texas, a labor trafficking worker. That's a really compelling story. There's also day labor, sweatshops or factories, domestic servitude. There was a victim here, Annie, in Houston, who was brought from another country, promised good wages and a good job. But when she got here, the story is always the same. The people that hired her took her papers, threatened her, physically abused her, threatened her family's safety, deprived her of food, made her work a long number of hours. And she was discovered, and those traffickers were taken to court, and they were required to pay over $100,000 in restitution to that nanny. There's also forced begging, like food service, and peddling, like magazine services and things like that. Next slide. Human trafficking does happen everywhere. We estimate 40 million victims worldwide, more than at any point in human history. This is a $150 billion annual industry. To give you some point of reference, Starbucks makes about $25 million a year. And probably a lot of you even had Starbucks this morning, so you can see the widespread impact. One victim can make a trafficker an annual income of up to $300,000 a year. So they are very highly motivated to recruit victims and will go to great lengths to groom them over long periods of time. A University of Texas study estimated about 313,000 victims in Texas and 79,000 minors and youth. Next. About 76% of sex trafficking victims are women and 27% are children. But it's important to know that even though the majority are women, that this does happen to men and boys as well. Next slide. Some of those risk factors are homelessness, family dysfunction or abuse, substance abuse. The number one risk factor for sex trafficking is sexual abuse as a child. And the longer and the more violent the abuse, the greater the risk, especially identification as LGBTQI. Those are significant risks. And I want to take a minute here to talk about all of the stories that you've probably seen going viral about children being rescued from sex trafficking and missing children. And that really is a grievous misperception of what's happening. You may have seen a story on your social media that goes something like this. I don't usually post things like this, but I was almost abducted by a trafficker tonight at my grocery store. And then they proceed to tell a scary story about a scary man following them around and trying to grab them or grab their child and that kind of thing. And kidnapping does occur, but it is way, way, way on the very bottom of the way that victims are recruited into trafficking. And that is not, the majority of the way that things are happening. And when it says children are missing, these are not children who are abducted from loving homes or supportive homes or from grocery store parking lots or from school. These are mostly children who are missing from foster care placements or juvenile justice placements who have run away. And so I think that's really important to know. Next slide. Again, you can see the human trafficking impact in Texas. This was, oh, I'm sorry, I went ahead too soon. There are differences, there are higher rates of survival sex. Boys that are in trafficking are less likely to have a trafficker, and they are more likely to be more independent and just work for survival sex on the street, which means they exchange sex for money or food or shelter. They do have lower rates of identification because there's more shame associated with this. There are fewer services available and some cultural perceptions and bias that occurs that prevents us from being able to recognize these victims. Next. In Texas, we see, again, this is from a University of Texas study that came out, about 79,000 minor victims in trafficking, 234 victims of labor trafficking, which you can see, the majority are labor trafficking victims, and that it costs the state of Texas approximately $6.6 billion. Next. A landmark study that came out showed that, and this is a reliable statistic, that 87.8% of sex trafficking survivors did see a healthcare professional while they were being trafficked without being identified as a victim. And I thought about this and thought, how can this be? Because nurses are highly educated, we're very professional, we give non-judgmental, unbiased care. But I give the analogy of going to the optometrist. You go in there, and as we walk into a room, our eyes work like that optometrist lens, don't they? We start looking at everything. We look at who's in the room, what are the things that we see, what are the things that we smell, what are the things that we hear? Is this interpersonal violence? Is this substance misuse? Is this homelessness? But we don't have that lens for trafficking. And you're thinking, is it clear 1 or clear 2? And we just don't have that lens to see potential trafficking. We have a lens for prostitution. We have a lens for domestic violence. We have a lens for drug misuse, but very few of us have that trafficking lens as a clinician. Next. And furthermore, many survivors report that the cost of care is added to their debt burden. So these victims are only going to present for health care when they are not able to work. They're not going to get preventive care very well. They're usually going to have poorly managed chronic illness. They're only going to report when they have a sexually transmitted infection that's so bad that they can't work, or they have an injury that's so bad that they can't work on the farm or work in domestic servitude. And when they go, the trafficker will say, well, you're costing me money and you're going to have to pay me for your medical bill, and that's added to your debt. So if they have a $2,500 debt added to their debt bondage, it makes it very difficult for them to even have the perception of getting out. So next slide, it's time to change that. We are on a mission to educate healthcare providers because we are ideally situated to respond to trafficking and to connect victims to services. Next. So next we'll get into how to identify and respond to victims of trafficking in a clinical setting. What is the role of the healthcare provider? And I'm going to say this again later on in the presentation, but I'm going to start with this now because this is really, really important. As I talk to you about encountering victims of trafficking, you'll be, very aggrieved and very upset and angry even that this is going on. And it gives us that kind of savior complex where we want to save patients. And that is actually a really harmful narrative. Many patients, many victims of trafficking enter their situation sometimes in what they perceive to be willingness. So I'm going to give you an example of Holly Austin Gibbs, who is a very prominent national anti-trafficking advocate, and she is a survivor. She was trafficked as a teenager out of Atlantic City. She grew up in Chuckerton, New Jersey. She wrote a really great book I would recommend called Walking Prey: How America's Youth Are Vulnerable to Sex Trafficking. And she met her trafficker in a mall. And that's one of the things she talks about, is that, these are not scary men waiting to kidnap you. These are very charming people. They look like they have, recruiters look like they have a lot of money. They have fancy cars. They have expensive clothes. They're going to show up at a high school party with kegs of beer. They're going to have backstage passes to the hottest concert in town. They're going to gift designer bags. And she was walking through and she said, I felt like a lot of teenage girls did, just kind of less than and not as pretty as and not as popular as. And she said this recruiter, who she didn't know was a recruiter at the time, just saw her and just kind of crooked his finger at her like, hey, come over here. She said, I wasn't afraid. I wasn't, there was nothing scary about the situation. She said, I was flattered. I was honored. And she said, I felt like for the first time in my life, someone had actually seen me. And he wrote his phone number on her hand and just said, call me. And that was it. There was no, in her mind, force or fraud or coercion. And so she called him. And she talked to him over a period of several weeks. And he gained her trust. He gave her all of the messages that she wanted to hear, that she was, in fact, more beautiful than all of her friends. And they were just jealous. And she could be a model. And why did her parents treat her like they did? And if they would just pay a little attention to her, she could really go somewhere and she could be something. And so finally, one night he asked her to meet him. And what she thought in her teenage mind was that they were going to go clubbing. And she met another equally attractive woman who was in her 20s and very glamorous. And she helped her get dressed up. They took her shopping. They bought her a fancy dress. They did her makeup. They did her hair. She felt like a princess. And this girl was what is called a bottom girl, or a bottom B, as in a derogatory term. And that was a victim that's been moved up in what they call the stable, or the cadre of victims. And so she was responsible for kind of getting these girls ready to go, and for also recruiting. So there's complexity there, because she's a criminal, but she's also a victim. And so what happened to Holly was that night she found herself on the streets of Atlantic City for sale, and she was picked up 3 days later and arrested, actually. And she said, when I got in there, in the police car, I did not feel like a victim. They treated me like a prostitute. And I thought, I went with this guy. I chose this. Nobody forced me. I made a stupid decision. I'm dumb. I feel terrible about myself. I'm not going to admit this to anybody, because people are going to say, how could you be so stupid? And she said for a long time, the most common question she got was, why didn't you run away? I mean, they weren't holding you there by gunpoint or anything. And she said she would give answers like, she didn't have any money, or she didn't know how to get a cab or how to get back, or she thought maybe her parents would be mad and not let her come back home. But finally, she said one day it clicked, and she said, I didn't, because I was a child and I didn't know what I was doing, and she was being victimized. So in saying that, it's really important for us to know what we can do as healthcare providers and what we cannot do. And we cannot save victims. Again, that's a harmful narrative. We can help victims to exit their trafficking situation. We can report child abuse. We can connect victims to appropriate services, but it is not our job to solve the whole problem right there when they present. Next slide, Sally. So some common healthcare misconceptions, let's start with that, with some facts versus myths, is of course the challenges are media portrayal, because we see all of these stories. A popular story came of, all of these children were rescued in a trailer in Georgia. But if you really read into the story and you read the facts that are in the story, the victims were victims who were mostly missing from foster care and from juvenile justice. Another kind of tragic part of that story is that there were a lot of arrests of children in that story. There's a lot of discrepancy between state to state as far as whether you can be arrested for prostitution or not, or even child prostitution. Here in Texas, a law passed both the House and the Senate to decriminalize actions of victims. So, for example, if a victim is forced to traffic drugs or steal something, while they're a victim of trafficking, that they would have protection or criminal immunity from that. And Governor Abbott actually vetoed that bill, I think largely because of his background and as a prosecutor. And his concern and stated rationale was that, that would take away the legal carrot of guaranteeing their being able to prosecute the trafficker. And this is one of the tragic things that I see, is because criminal justice is way ahead of healthcare. The criminal justice paradigm is justice. We want to get the bad guy or the bad girl, the bad person, and we want to put them in jail and get justice for the victim. And that is a really important part of this story. But as healthcare providers, we know that's only part of the story. That's only the beginning of this victim's journey to emotional, relational, spiritual, social, physical, and emotional health and mental health. And so it's very difficult. So for us as anti-trafficking advocates, we see here's a child who has been abused and traumatized and forced to work or perform sex acts, and then they're having to face that and relive all of that in court for testimony. And so somehow we've got to find a better answer there. And so that's another problem with the media portrayal of what this trafficking is. There's also a significant underrepresentation of labor trafficking victims in the media. I think it doesn't make as sellable of a story, and so those stories are often neglected, and we watch the media as nurses. We see those stories, and so that subtly and subconsciously affects our perception. We also have a perception of prostitution. We may come in and we may not have a judgmental attitude towards someone who is a prostitute, but we may see that as a choice and not as something that is forced. Because again, a lot of these victims, what happens is and most of the victims I've worked with, they've been groomed into a trafficking situation, whether for labor or for sex. And let me give you a couple of examples here. One would be labor trafficking victims, nurses, a group of nurses that were recruited from the Philippines. They were told, you'll have a great job here in the United States, you'll make good money, you'll be able to support your family, we'll give you a place to live. And so they come over here, and again, their papers are taken, they're threatened, their wages are garnished, and they're afraid. They don't know the legal system here. They're threatened with harm to their family or to the other nurses that were with them. And these are nurses that are coming and working every day in the hospital and seeming like everything is fine, but they really are living in very dire conditions. And so another, example of how trafficking victims are groomed is usually it's someone that they know. They may meet them. Trafficking is moving from the street to the smartphone. So a lot of this recruiting is happening over social media, especially with minor victims who have public Facebook profiles or Instagram or Snapchat or TikTok profiles, and they're vulnerable and they ingratiate themselves into their friend network. And before you know it, you think it's a friend. And at first, they look for vulnerability. Traffickers look for vulnerability. They look for kids that are lonely, kids that have poor self-esteem, kids that have poor home lives, kids that have gender identity issues. Those are all the kids that they're going to target because they can speak into those vulnerabilities. And this may be a kid or even an adult victim that's never experienced true love or healthy relationships before. And so they think this person truly loves them, and they may give them gifts, and they may give them food, and they may give them shelter. And then it kind of turns. There's something that turns. There's, I spent all this money on you, and now I don't have any money to pay the rent. But if you just sleep with my friends, then that I'll get enough money. And so you kind of think, okay, well, I'm just doing this. And or they do something, and then all of a sudden they have blackmail. And they say, I have these pictures of you or these videos of you, and you don't do what I say. I'm going to show these to your parents, to the school, to your employer, to a porn revenge site. So those are all things that are there. We also may see people as drug addicts. We may see people presenting a suicidal ideation. I had a teenage victim present to me. I was working in a community regional hospital, and sadly, I do have a lot of teenage patients that present as suicidal, and they wait for medical clearance from me before they can go to inpatient therapy. And I had one girl that came in who had every drug you could imagine in her system. She had self-harming behavior. She had dropped out of school. She had a couple of misdemeanor criminal convictions for shoplifting and things like that. And I think, before I knew anything about trafficking, I labeled her, I did, as troubled. And I thought, oh, this is a troubled teen. And my heart went out to her and I wanted to help her as much as I possibly could. But, I didn't know what I could do to help her. And as I talked to her, if I had said, are you perhaps by chance a victim of trafficking? And she said, oh my gosh, yes, thank you so much. I've been writing secret messages to the pizza delivery guy every time he comes. That's just not how it happened. And what happened is she was actually being trafficked by her father. And her mindset, though, was, I have a great dad because, I am such a screw up. I'm the reason my parents got divorced in the first place. And I dropped out of school and I'm addicted to, drugs, and I have a criminal conviction, and I'm just a terrible person. But you know what? He lets me sleep with his friends to help pay the rent, and he lets me stay there. So I have a great dad. That is her mindset. And that's the mindset of a lot of victims, feeling like they've somehow gotten themselves into this situation and that they are to blame. They may present with self-harming behaviors. And actually, we really would like for this to be a joint commission standard. And about 3 years ago, my organization, MapNav, we wrote to the president of the Joint Commission, and they wrote us back a very nice letter saying, thanks, but no thanks, don't see how this relates. But just about a year after that, they issued a Sentinel bulletin about trafficking victims, and especially related to suicidal ideation, and that was happening on the grounds of the healthcare session. We also have misperceptions on societal perceptions of traffickers, and we are susceptible to trafficker deception. So, a trafficker is the same thing as a pimp. I don't like to use that word because it conveys societal glorification that's undeserved. When you say that word, you have a certain image that comes to your mind, and that's just not how it is. Traffickers are pastors and coaches and military veterans and mothers and all kinds of people that you would not suspect, and they're very duplicitous. So you could just go to a Google search engine, Google human trafficking. I live in Houston, and I would type Houston and click on the news and just see what kind of traffickers have been arrested in your community and what kind of cases are there. And you may be surprised to see what's going on in your community. Next slide, Sally. Patients can present anywhere. They present in hospitals, emergency rooms, acute care, primary care, specialty care. We're also seeing a significant increase in victims presenting for aesthetic or cosmetic practices because in sex trafficking, in some genres of that, the more attractive a victim is, the more lucrative that their income can be. And I actually just wrote an article for the Journal of Pediatric Surgical Nurses about victims presenting for surgical care because they may have had trauma, or they may have had trauma that's not treated, and then they're presenting for deformity or for a lack of ability that comes from an untreated injury. There also was an egregious case of an adult victim who got implants in her buttocks, but very, poorly done, infected, presented to multiple, points of care to have care, and no one ever asked her about these things. I've seen victims present in the newborn nursery where we have traffickers who have women who are having babies, maybe to traffic the babies, or also as a means of control to make sure that that trafficked victim never leaves, that they will stay to take care of their baby. So I've seen victims that have presented there. I've had a victim present in my primary care clinic, which I was just by myself, and had a 4-year-old girl present for a UTI, which was not uncommon. With her aunt, she was a new patient to me, and turned out she was being trafficked. And here I am in my clinic all by myself, not knowing, where is the father? Am I safe? Are my patients safe? Is my staff safe? How am I going to connect this patient to services? And that really hit home to me, the need to be aware. Even here at Texas Children's, their first Sentinel event was a was a police officer who recognized a trafficker when the healthcare providers did not, and they recognized that they needed to equip their members. So next, it's really important to have core principles of a trauma-informed approach. And a trauma-informed approach is not just a checklist. This should be a way of being. The Missouri model is a great example, and that's in my references there, of a way to create a trauma-informed institution. Safety is of the utmost importance, safety for your patients, safety for you as a healthcare provider. And I think that's something that we're talking a lot about now in COVID. And if you haven't seen the article from Sigma about nurses as angels and heroes, and I would encourage you to look at it, and the detrimental narrative that is that, we are not called to put ourselves in harm's way, although sometimes we do recognize that, but it shouldn't be something that we are expected to do. And so this can be a situation of safety, so you need to make sure that you think through those things. There needs to be trustworthiness and transparency. This is another critical intersection with law enforcement, because law enforcement is allowed to lie to their patients or lie to their arrestees in order to get a confession. They can tell them anything they want to tell them, and kind of the ends justifies the means, whereas healthcare, we don't lie to our patients at all. So that is that can be a real culture clash. You want peer support. You need to have an organization where a nurse can come to you and say, this is probably not the victim, or this is the patient for me to care for. If you have trauma in your past, then that's probably, it needs to be okay for you to say, I think this patient needs to be assigned to someone else. Or recognizing vicarious trauma. We see horrific things, and do we have the appropriate peer support? Collaborating across disciplines is important. Empowering the victims is important. Having cultural humility and cultural responsiveness is critical. And the Missouri model, like I said, is a great example. Okay, next slide. We'll talk about top risk factors, and go ahead and go on, Sally. Labor trafficking is going to be immigration status, having recruitment debt, being economically disadvantaged, low levels of formal education, and just arriving as foreign nationals. Those are going to be high risk factors for labor trafficking. Next, common characteristics of sex trafficking. Again, if there's addiction in the home, runaway or homelessness. That's another common statistic that's cited, that a victim of trafficking is approached within 72 hours by a trafficker, which is not exactly accurate, but we do know that they are at high risk. History of physical abuse, again, gang involvement. Gangs often will use trafficking as a means of control. Next. A lot of times these victims, child victims in particular, are already in the system, CPS, juvenile justice, and they are extremely vulnerable to exploitation through trafficking. These kids are tough and they've learned to survive, and so they kind of thrive in that situation. I was in a sex trafficking conference in San Diego with an adult survivor, and she got very nervous when she was talking to me, and fidgety and just agitated to the point of, I finally asked her, what's wrong? And she told me that she got very nervous when she was talking to people like me, because she considered me a lady, was her word, and that she was not one. And even all of those years later, it's very difficult, especially adult victims who begin to be traumatized as children. Their emotional and mental and cognitive development arrests. So you may have a 25, 30-year-old victim who acts like they're 15. Next. Other common characteristics are going to be learning disabilities, developmental delay, if they're sexually exploited by family or peers, which sadly happens quite often, and lack of social support and emotional distress. Traffickers know these things, and these are all the things that they're looking for. Next. The less tangible characteristics include lack of identity or poor self-concept, a desire to belong, they need protection, or they want nice things. And so again, this is a perfect opportunity for social media recruit. Next. Traffickers prey on unmet needs. They'll ask, do you need love? Do you need a place to stay? Are you lonely? Need a protector? Have a dream that seems impossible? These are all things that go. There was one case where a guy became a regular customer at a cafe and trafficked a waitress after a year of getting to know her dreams and promising her a career as a model. Next. As I told you, trafficking is moving from the street to the smartphone, so they take advantage of their cognitive ability by pretending to be the same age or coming from a similar social group or background and luring them into sexting regarding blackmail. They may think that they're sexting with another teenager, but all of a sudden they have an image that they use for blackmail. And these warning signs are similar to signs you might see with drug abuse and use. Next. Some safety tips would be to protect children by educating them on how to protect their online presence, setting all their social media platforms to private, using a stock photo instead of a personal profile photo so they're not easily identifiable as a minor, disabling geotagging. I have had students who are trafficked by using geotagging and following them around and being able to exploit them more. And knowing that there's no social media platform that's approved for use under 13 years of age in the United States, so it shouldn't even be a question until 13 years. Next, we need to recognize that traffickers accompany victims to medical care. They may pose as a friend or family member or romantic partner, or it may be obvious that they're a trafficker. They may look like they may be a diplomat because they have diplomat immunity. They may be a legitimate employer. So it's important for us to have a healthy degree of skepticism. Next, traffickers are usually going to fill out the patient's paperwork. They're going to do all the talking. They're going to answer the question. They're going to have that patient's documentation. Next. So what is life like for victims of sex trafficking? Next. The realities of life are victims are considered commodities by their traffickers, and buyers are violent. They may beat a victim every time they touch a doorknob so that they train victims not to touch a doorknob. And again, they just look at them as a commodity to make money, so they may move them around frequently. And victims that present may not know what their address is or what city they're in or what day it is. They're often used drugs to control them. There's a trafficker who even wrote a handbook on how to maximize drug use so that they would, even if they tried to leave, they would come back to you within 3 hours because of their dependence on drugs. They also, like I said, lack preventive health care. There's no safety training for labor trafficking victims. They may have unsanitary fixes. They may, one thing we see is, they're forced to work sex trafficking victims through menstruation, so they may put foreign objects in their vagina or those kinds of things. Next, their living, working conditions are pretty terrible. They're crowded, they're not sanitary, they're exhausted, they're sleep deprived, they use drugs to stay awake to work longer, and then they use drugs to go to sleep because they've taken so many drugs to stay awake. They may have toxic exposures, poor nutrition, dehydration, overexposure. They're on the run. They may be, there may be contaminants, and they have a diminished quality of life. Next, like I told you, victims have often been subjected to severe complex forms of interpersonal trauma, and they are not the easiest patients to deal with. They may be verbally abusive, they may be physically abusive, they may be destructive in the exam room, they may spit. They're trying to survive, and we have to remember that. Next are barriers to identification. Like I told you, they feel shame or guilt. They just may feel isolated, hopeless. They are controlled every moment. They may have 2 cell phones where the trafficker knows everywhere they go. They're afraid of retaliation to themselves or their family members. They're afraid they'll be reported to social services. They're afraid they'll be arrested. They're afraid they'll be deported. And next, they're also afraid of police corruption. They don't understand the healthcare system. They're afraid of getting someone in trouble. And mostly there's just complex trauma bonding that they feel like, they may not have ever gotten a driver's license, or they may not have gone to the grocery store. Or ever fixed themselves a meal or gone to a bake. And so it's important they feel dependent on their trafficker. Next. So the indicators that should raise suspicion next are environmental. So if they have questionable employment, abusive relationships, substance abuse, homelessness, they don't answer questions or looking to others to answer questions, that's concerning. Next is emotional, mental, or psychological. They may provide contradictory information. They may present as depressed, suicidal, hopeless. They may have panic attacks and symptoms of trauma or aggression. Next. Other symptoms of post-traumatic stress disorder. They may be hyper alert or dissociated. They may be numb. They may have, again, they'll have complex trauma bonding. Next. Tattoos are common. Traffickers use these in both labor and sex trafficking to brand their victims. You can even work with your local police department. They usually will know the common tattoos that are associated with certain gangs or certain traffickers. In Houston, there was one trafficker who branded his victims as the Rooster because that was his trafficker name. They often will have dollar signs or barcodes or so-and-so's girl, or if it says bottom, that can be like what I told you on that. They may have untreated injuries, multiple STIs or UTIs, especially if you see a minor with what you would view as a promiscuous sexual history. That should be a red flag to you. Or if they have a history of multiple pregnancies or abortions, PID, a pregnancy with no care, or trauma to the vagina or the rectum, those should be red flags. Not one of these indicates trafficking, but they all indicate potential trafficking. Next. The other things are if they have evidence of abuse or assault or genital discharge. They're coming in for testing for pregnancy or STI or retained foreign body. If they have evidence of physical trauma or abuse like burns or ligature marks, neck or jaw problems, sometimes from being beaten and sometimes from repeated forced oral sex. Next. In their general health, a lot of times they come in with nonspecific complaints, just headaches, fatigue, backache, abdominal pain, especially labor trafficking victims. Next. They may also have untreated dental issues, or I had a victim that presented a teenage victim in DKA. She constantly presented in DKA. Well, she wasn't taking care of her diabetes, which teenagers often didn't do, but it was because she was being trafficked. There's often malnutrition, stunted growth because food can be used as a form of control, and industrial injuries. Next. As I told you, addiction is used by abusers to control and create dependency. This increases the risk of bloodborne diseases, including HIV and especially hepatitis. They may be suffering from withdrawal symptoms by the time they get to you, or overdose. They use all kinds of illegal, illicit, and prescription drugs. Next. As I talked to you about, the other possibilities on our lens should be domestic violence, rape, child abuse, homelessness, interpersonal violence, or substance misuse. Just because they have one of those doesn't mean they're a victim of trafficking, but it means they're at increased risk, and you should assess it. All right, next is, what do victims and survivors need to know? That there is a way out, and it is not our job to rescue them or to force them to leave their trafficking situation, especially if they're adults. They have autonomy and they have the right to make their own decisions. Next, best practices. You want to establish trust and ask permission. Try to get that victim alone so you can speak privately with them, separate from the person who brought them in. Use your authority to create a safe space for talking. So whether that's walking them to the bathroom to get a urine specimen or an x-ray, you want to have them away from their phone and that trafficker. You also want to limit staff involved, because if this is going to be a criminal case, you don't want all your staff going for testimony if that happens. But also, just recognize this is a dangerous situation. This isn't something you should be talking about at the water cooler or the nurse's station. And you want to preserve their autonomy in their healthcare decisions. Let them make as many decisions as possible, even if that's as simple as, would you like to be in room 3 or room 4? Would you like to sit on the table or sit on the chair? Would you like me to take your temperature first or your blood pressure first? Next. I know Marianne is going to talk in a little bit about the importance of, when you create screening tools, making this with scientific validity and reliability. But when you're talking to the patient, you always want to use a professional interpreter and use the same words the patient's using. So if they say, I got beat down for trying to choose up because I didn't make my stack, and I got to get back to the stable, and you're thinking, I have no idea what that even means, because there is a whole lingo that goes along with trafficking. And just ask them and say, I'm not sure I understand what that means. Can you explain that to me? And they'll tell you, because it's very much their life, what they call the life. So be open to those unfamiliar narratives and stories. And we need to use trauma-informed and patient-centered and a non-judgmental approach. Next. So as I was saying, right now, the best evidence shows just asking simple, direct questions is the best therapeutic way, but there are a lot of really good practices for screening tools, and there's not one size fits all, not one screening tool that's recommended for universal use. And like I told you, Marion is going to tell you about that in just a little bit. Okay, next, if you suspect labor trafficking, these are some of the kinds of questions you can ask. What kind of work do you do? Where do you eat? Where do you sleep? Are you being paid? Do you owe money to your employer? You'll notice that these are not forensic interview questions. If you are not a trained SANE nurse, go ahead to the next slide so you can look at those next questions. If you're not a trained SANE, if you're not trained in forensic interviewing, if you're not a police officer, then don't act like one. It's very important that you recognize that your scope of practice is nursing. Your responsibility is to respond to their immediate healthcare needs. Sometimes that gets lost in the shuffle. They come in and you get all distracted by, oh my gosh, this is a victim of trafficking. We got to do this and this and that. And you forget they came in for a UTI. And so you want to make sure that you treat those needs that they have. Provide them with a safe space and connect them to services. Trying to get them to tell you every nitty-gritty detail that happened is not appropriate. It will likely traumatize you. It will likely traumatize them. And you need to wait and connect them to someone that can do that in a skilled way. Next, an important differentiation is if you suspect a youth or a child, we are, go ahead and go to the next one, Sally. We are obligated reporters. We have to report. So next, there is a screening tool that was developed by actually Jordan Greenbaum, who is the Children's Healthcare of Atlanta and is working with me on developing core competencies, talking about just some simple initial questions that are here. Just, you know, always talking about, hey, normalizing it a little bit so they feel a little safer to ask, is saying, some kids do this. Has this happened to you? Go ahead and go to the next one. And again, you know, if so, and just asking them, not in a judgmental way, but just in a very normal way. But if you get a positive response, then you proceed to these secondary questions, which next are, you know, has a boyfriend or a girlfriend or anybody forced you to do something sexual with another person? Do you feel comfortable telling me about it? And same there. Next, talking about, hey, sometimes when you really need money, you might feel desperate to trade that, you know, sex for money. Have you ever done that? And then do you feel comfortable talking to me about it? Next, some specific questions for very young children would be, do people give money to your parents when you stay with them? Do you have to do things that grown-ups, with grown-ups that you don't want to do? Does someone tell you to say those things? Have you ever been hurt by grown-ups? And again, if you have enough information, once you have enough information that obligates you to make a report, once you get to that point where you're, okay, I know I'm reporting this to CPS, you don't need to go any further. You know, you just don't, because that can be traumatic and you need to leave that to the professionals. Next, really important is to communicate hope. If you think your victim is a victim of human trafficking, they may not be ready, especially as an adult victim, to get help then. But knowing that healthcare is a safe place they can come back is important. So saying you have rights, you're not alone, this is not your fault. I can't tell you how many victims have told me that a nurse told them this, and this is the first time they ever even considered that this was not their fault or they might be a victim. It takes a lot for a person in trafficking to say, I am a victim. Next. If you have a victim that is, you know, or a patient that's really difficult, that just is sleep deprived, find somewhere where they can sleep and have something to eat, and then they can be in a better place to be able to work with you and address their healthcare needs. Next is assessing safety if you think your patient is a victim. So a safety plan is really important, and you have these slides, you can go back and look at that. Next, you're gonna make referrals if you think your patient is a victim. There are a lot of, what I'm seeing a lot is advocates, survivor advocates that are available 24/7, who are trained in being able to talk to victim advocates. They can be kind of a go-between between law enforcement and healthcare. So healthcare can take care of their healthcare needs, law enforcement can take care of their criminal justice needs, but survivor advocates often have been in their shoes and are effective there. But it may be the social worker, it may be just whoever that they need to do. There are ICD-10 codes, and you're going to hear about those in just a little bit. Next, it's really important to remember that we are mandatory reporters, and you do have to report if you suspect that a victim is under 18 and is a victim of trafficking or abuse. All right, next, again, this is important, like I told you, if we identify them as a victim of trafficking, because it helps give them additional resources. Next, some local resources. There are Unbound chapters all over the state of Texas. There's a great one in Fort Worth that has survivor advocates that are available 24/7 to come to any healthcare environment for free that will come. And there's also the human trafficking hotline. This is easy to memorize. It's 1-800-3737-888, or you can text help to be free. This is also for healthcare providers to ask for information. There were a lot of people that, encouraging the public to use this, but since the rise of Wayfair, Gate, and all of those things, this hotline has actually been flooded with inappropriate reports, and so that diminishes the ability of people to get help. All right, next. If the patient is not ready to accept help, go ahead and go to that. Yeah, there you go. You want to validate and normalize their feelings and give referrals privately. Again, emphasizing, we do not want to rescue this patient. And yeah, here, referrals for help, you don't want to give them written material either. You want to tell them, you can come back here, or here's the human trafficking hotline number, or there's an organization, in your community where you can go for help, but don't give them pamphlets. Don't, put all this information in their patient portal, because that can put them at risk. So what not to do is, you don't want to attempt to rescue the patient. You want to help them exit their trafficking situation. We do not want to ask about their immigration status. That is threatening and can make them afraid. And I've seen some tragic stories of well-intentioned healthcare providers who have patients that are reported and then have immigration problems, and that's really tragic. You don't want to make promises that you can't keep, and you don't ever want to force, deceive, or coerce victims in efforts to save them. Victims will come to some point in their journey where they self-identify as victims, and then they will at some point say, feel comfortable to say that they're a survivor and go on, but that is a label that they should give themselves. Next. So there's no way I'm going to be able to go into all of the protocols and how you make one. That's a whole nother presentation, but what I can tell you is that you should have a protocol. You should have policies in place. Whether you're at a small place or a big place, you need to have policies in place to protect and equip you for what to do. As you see on the screen, these are all things that should be in your protocol. Heal Trafficking has one, or Dignity Health. If you go to NAPNAP Partners, you can see that down in the bottom left of your screen, napnappartners.org. You'll see all of these resources linked there, talking about what you should do. And we can also connect you with what we call an ACT advocate to help you, put you in the right direction to develop a protocol. But it should include all of these things. Next slide.
Dr. Peck, we have about 5 minutes.
All right, great. That is perfect timing here. So we also you should be, how do you screen and identify for victims in your setting? How do you address safety? What do you do if they refuse care? How do you discharge, and where do you refer them to? What are the clinical protocols behind order sets? So for example, using the ICD-10 codes I showed, do they report out as confidential? Next. These ICD-10 codes were put forward at an effort mostly by Jordan Greenbaum. You can see that they cover sexual exploitation and labor exploitation, confirmed and suspected, and adult and child. And these are really important as far as data collection, so that we know where and how to develop service provision there. Next. Another great consideration is the PAIR tool. Again, this is available here, but it's also linked on napnappartners.org. And it helps you to put in a trauma-informed approach, having privacy, education, and asking in a trauma-informed way, and then respecting patient wishes and responding to their needs. Next. This is the call to action. So what I call you to do is to develop a protocol with Heal Trafficking. You can see I put that link. It looks like this on the next slide, and you can see there are pieces that you can piece together for your specific clinical setting. And next is the Shared Hope International Eye Care Guide that was written by a nurse, Dr. Kathy Miller. And it has a lot of information in there, detailed information about recognizing and caring for domestic minor sex trafficking victims. Next, who should be on your team is SANE nurse, and everybody should be on the team. Security, housekeeping, ancillary services, infectious disease, social work, psychiatry, supervisors, administration, because, even in a patient room, the maintenance staff may hear, or housekeeping staff may hear something that you don't necessarily see as a healthcare provider. And next is a quote that they have in this is a slide deck that we take all over, and a quote they put in here from me. And I would just admonish you that, this is hard. This is really hard stuff, but we didn't choose this career because it's easy. We can do hard things. We see trauma, we see grief, we see illness, we see people at really difficult points in their life, and we are ideally situated to intervene and respond in a trauma-informed way. And so next is, again, the Human Trafficking Hotline, 888-3737, 888. And the last thing I'll say, the last slide, is calls to action for your organization. So you think, what do I do going from here? On the next slide. And there are things that you can do to work with your leadership to implement a protocol. You can establish an organizational task force or work group on trafficking, child and adult. You can establish annual training for all employees. You can make it a part of onboarding. You can develop, this is so important, to develop collaborations with local and state law enforcement, and know, because even here, I live in Houston, it depends. If you're in Brazoria County, it's going to be different than you're in Galveston County or Harris County. So it's important to know what resources they have and to use the ICD-10 codes, which you will hear about next. So with that, I will conclude my presentation. You will have access to the slides and all of the resources on here. Again, they're all at napnappartners.org. I want to thank you for your attention during this difficult topic, and thank you for all that you do as nurses, especially during this year of the nurse and this time of COVID. And I'll be happy, Candace, to take some questions.
Very good. Thank you, Dr. Peck. Sally, do we have any questions listed out in the chat?
No, we don't have any questions at this point. If y'all have got questions, please type them into the question box there.
Okay.
Some of the questions I commonly get, are about, some of you out there listening will likely think, I really want to know more. And so what can I do, to know more from here? And on napnappartners.org, we have a 3-part education series that's a deeper dive into what human trafficking is and healthcare intersection. 101 is more of what I've told you now about human trafficking. 102 is more detailed on the clinical response. And 103 is more details about the intersection between the criminal and federal response. So you can go and you can take those online. You can also take our ACT Advocate training. We have the Alliance for Children and Trafficking. And if you think, hey, I would like to, bring this to my organization, or have, a presenter come and present to my church group or my Girl Scout group or my, my unit at my hospital or my clinic, you can go onto napnappartners.org and request an ACT Advocate, and we can provide free training, as we can also do through Unbound. Through Unbound Houston or Unbound Fort Worth, we provide free training all over the country and Unbound all over the state of Texas. We have continuing education that's accredited for nurses that we can do. So you can email me, you can message me through Unbound, you can message me through NapNap Partners. And if you'd like to become an ACT Advocate and start making these presentations, we have a Train the Trainer program. That's about a day's worth of training that you could train and be one of our representatives and on our Speakers Bureau.
We do have a question that's come up. When should we introduce students to this topic?
Love that question. Thank you to whoever asked it. Right now, there are no curricular standards for trafficking. There are several really good journal articles about how and when to do it. There's one 3-part series in particular talking about that. We know that just a 1-hour education is not generally sufficient for long-term change, but for this for this 1 hour that we have, we know that it has spurred nurses on to further work. They should be introduced to it as soon as possible, and you should really meet with your faculty to discuss how to integrate it across the program. You can integrate it into simulation. It can be integrated into a professional role course. It could be integrated into a trauma module for acute care. It can be also, I've been writing in textbooks, and mostly we've been putting it in to differentiate from interpersonal violence or domestic violence or child abuse. So if you have a pediatric course, that would be a great place to put it to, but it can be integrated in a lot of different places. Faculty can take the ACT Advocate training, which is available online for a pretty low cost of, I think, about $30. And it's a day's worth of training that would equip you as a faculty member to have enough expertise to be able to speak about this and to develop curriculum related to that. You could also, we've been integrating some of our curriculum into nursing programs. And so if that's something that you would like to do, you can message me and we can talk about how to do that and give you ready-made modules that were developed in conjunction with the American Academy of Pediatrics for students. But one thing to watch for is the core competencies that should be released in January that will be coming from the Department of Health and Human Services and NAPNAP and HEAL Trafficking. It will also include core competencies for academic institutions and what you need to do to be ready for that. So be watching for that.
Okay, just a comment that we had excellent presentation. We're now including a human trafficking certificate training in our psychiatric clinical assignments.
Yay, that's fantastic. That's wonderful. Whoever is doing that, I really appreciate it.
Okay, I think those are all the questions that well, let's see. One more question here. Will these core competencies be on the NAPNAP website?
They absolutely will. And actually, we expect this to be a pretty significant press release. Right now, we're working to get any nursing organization that we can to sign on. So if you are with a nursing organization that would like to consider being an endorser of these, we're about to start seeking out endorsements so that we can have as many as possible. They will be for medicine, social work, and behavioral health and nursing. NAPNAP has been the representation for nursing. There'll be core competencies for individuals, for healthcare organizations, and for academic institutions. And so they should be released there. We're working right now with a journal to publish it as a special issue as well.
Okay, those are all the questions that we've had.
Okay, well, thank you so much. And again, you can reach me through napnappartners.org. You can reach me through unboundhouston.org or unboundfortworth.org, or you can email me at jessica_peck@baylor.edu. And there are some supplemental slides down there on the bottom you can access. And with that, I'll give it over to introduce Mary Ann.
Thank you, Dr. Peck. Our next speaker is Mary Ann Contreras. She is the Violence and Injury Prevention Manager in Trauma Services at John Peter Smith Health Network in Fort Worth, Texas. She has been a registered nurse for 39 years, specializing in the fields of trauma, emergency, and critical care. She has practiced in the state of Texas, Virginia, and Florida. She studies trauma, behavior, environment, and policy to develop, implement, and evaluate prevention initiatives. Mary Ann?
I'm here. Thank you so much. I appreciate that. And I absolutely, every time I hear Jessica speak, I learn more and more things. I'm like, oh, we have to go add this to some of our stuff that we're doing. But I'm really happy to be here today, and I appreciate the opportunity. And as we move on to the next slide, I would like to let you all know that there are going to be some comments or some slides that could cause you to have some triggering or some uncomfortable feelings. And I just wanted to let you know ahead of time so that you do however it is that you can do to be comfortable in this talk. A little bit about JPS Health Network is that we are the only level 1 trauma center in Tarrant County. We're a tax-supported healthcare system. We have a psych emergency department that also includes an inpatient behavioral health unit. We serve residents in the city of Fort Worth and several surrounding counties. Next slide. So Jessica talked a lot about human trafficking, and I'm going to talk a little bit about the intersection of human trafficking and intimate partner violence or domestic violence. Intimate partner violence and domestic violence is based on the abuser using power and control over a victim or over a person. And there's different, this is out of Duluth, Minnesota, and there's different spokes on this wheel that you see, but they're very, very similar, both with intimate partner violence and with sex and labor trafficking. There's a lot of intimidation, psychological or physical threats, emotional threats, causing someone to feel guilty, making them feel like they have to do something they don't want to do. Something that both traffickers and abusers in intimate partner violence relationships do a lot is isolate. They control what the victim does. They control who they interact with, where they go, who they see. They may minimize some of the abuse, whether it's psychological abuse or physical abuse. They may make threats to the victim's children, saying, I'm going to take your kids away if you say anything. There's a lot of coercion that goes along with it, as well as economic impacts to the victim. Next slide. On this slide, you can see that's one of my favorite little drawings there. That's very easy to identify with somebody that controls you. So the abuser, uses a lot of force or threats that cause a compliance from the victim. They compel or dispel a particular response, and it is a long-term grooming process, both, as Jessica had explained, in the actual human trafficking grooming, as well as within intimate partner violence. The victim learns what the controller's preferred choices are, and they comply in order to survive or in order to please. The abuser uses micro-regulating processes to control their partner's behavior. They limit their options. They deprive the victim of independent judgment. And this is really hard to, like I said, it's very hard to pick up on when you first initially meet your patients. Next slide. So we've been screening now for about a year and a half, almost 2 years now, for intimate partner violence and human trafficking as well. And so this presentation or my talk today is short, but it's kind of an update on what we've seen in response to our putting this in our practice in several areas of our hospital. But as Jessica said earlier, talking about nursing organizations signing on to doing the right thing. So our responsibility as nurses in identifying and offering resources to victims of both trafficking and intimate partner violence are backed up by the Emergency Nurses Association, by the Association of Women's Health, Obstetrics and Neonatal Nurses, by the U.S. National Institute of Health, and even U.S. News and World Report notes that, especially in the Year of the Nurse, that we are seen as the most honest and ethical people among a list of professions for 18 years in a row. So, you know, people look to us for not only their physical care, but they look to us in a trusting manner, and they look to us for advice. They look to us for knowledge to where to refer people. Next slide. As nurses and as nurses who work in healthcare organizations, we are also guided by our regulatory agencies, such as the Joint Commission. And the Joint Commission does require screening for intimate partner violence. What's interesting about the Joint Commission is they don't specify a specific tool or specific referrals. They're relying on us to identify those in the areas that we practice in. Next slide. The American College of Surgeons Committee on Trauma is the accrediting body for trauma centers. And recently in their best practice guidelines for trauma center is a guideline on abuse and recognizing abuse and screening for abuse. And I'm really proud of this because we actually got put in the book on page 122, if you want to look that up. And it is a part of our referral process that includes acceptance that includes, screening and referring for both intimate partner violence and for human trafficking. It also, as Jessica mentioned earlier, talks about the acceptance of adults who refuse any referral. That's really important, and I like that she highlighted that a lot. Next slide. So as nurses working in today's world, we all work with the electronic medical record. It's been around now for quite some time. And like most technology, it has progressed. But at the end of the day, all healthcare providers need to assess that patient and not only depend on the electronic medical record. Next slide. So in our practice of screening for intimate partner violence, we noticed that people did exactly what that previous slide did. They looked at their computer, they asked the questions very quick and very short. And so we tried in several focus groups, we tried different ways to figure out ways to have the nurse acknowledge that patient's presence and make them feel more at ease. And we developed this badge buddy or badge backer. And it hangs on all of our badges around our neck, like we all wear. And we show it to our patients and we ask them in a normalized fashion, how often does your partner hurt or insult you or threaten you? And we ask it on a scale of 1 to 5. And if you notice, there's even colors on that badge backer. The blue is kind of a soothing, calming color, and red is an alarming color to help with some of our literacy that different levels of literacy that we experience in our organization. And at the end of four questions, it gives a score that lets us know if that person is at risk for violence in their home. Since we started using the Badge Buddy, we have gotten an increased compliance in even just patients accepting the screening and even accepting referrals. Next slide. On the back of the Badge Buddy, we put our local resources that we have in our area. And these are important that it's a quick reference guide, not necessarily for the patient, but for the person that's asking the question. It lets them know, oh, this person may need shelter or may need the National Human Trafficking Hotline. And it gives them the resources that they have easily accessible instead of having to go and hunt and search for those numbers. We, as Jessica mentioned earlier, we also do not give pamphlets. So when we identify someone that is positive for intimate partner violence or human trafficking, we offer them right then and there a method to call. Of course, in all the safe mannerisms with them being alone and that, but we give them the phone if they would like to call and be additionally screened at the National Human Trafficking Hotline or at Safe Haven, our sheltering organization, or if they want to go to our Family Justice Center, which is one safe place. Next slide. So what we've seen since November of 18, when we first initiated a pilot in some limited areas, this is a graph that shows you our referrals that were accepted versus refusals. And the data of the positive research or positive referrals is in blue. These are when patients accepted a referral. And these referrals have increased over time as nurses have become more comfortable in asking these screening questions in a normalized manner and in a trauma-informed manner. The red line is the refusals, where the patient said, no, not right now. Now you see a little gap in there in April, and we had some issues with COVID and with some of our electronic systems. And make it short, I'm just going to tell you that I think COVID ate our April data. But the refusals over the last year have been fairly consistent, but we have seen an increase in the referral acceptance, and those have risen sharply over the summer. Next slide. So this graph is comparing what we're finding during this time that we've been doing these screenings in several areas of our organization. It is comparing the victimology similarity. So what we're seeing is in red is possible human trafficking. In our screen, there is not an identified validated health screen for human trafficking. We only have a validated tool that we use for intimate partner violence. And so we call them potentially positive human traffic victims. And if you see there, they're very similar, the graphs are. So this tells us that the victimology of both intimate partner violence and human trafficking is very similar, much like on the power and control wheel. May had 47 patients that were identified as positive for intimate partner violence, and 38 of those, 38 people who were identified as potentially positive for human trafficking. Next slide. So when we look into our data and we dug a little bit deeper into the medical record of those who screened positive, what we discovered was a trend of suicidal ideation. So this is kind of new for us. We're just discovering this. Suicidal ideation, or some attempt at some point within 40% of our victims who were positive for intimate partner violence. Our plan our plan before COVID was to move forward in educating our behavioral health unit and our folks that work over there about the screening for both intimate partner and human trafficking. But since COVID has hit, we've had to temporarily halt this next step. That's in our plans. You can see that we're screening currently in 6 areas. Our emergency department over this time period averages about 30 positive intimate partner violence victims and potential human trafficking screens each month. So it's pretty consistent. And what we also have noticed that before COVID, our severity of positive scoring for intimate partner violence was lower. Since COVID has hit, the severity, the higher number in the screening tool has really escalated since COVID. Overall, across all 6 areas in our organization where we screen, we're averaging about 85% compliance during this time period, which is really an awesome thing. We started at 12%. So it's taken less than a couple of years to actually average 85% compliance of screening all patients at these points of entry. Another thing that we have also noticed in analyzing some of this data over this past year is nearly half of all of our positive intimate partner violence patients have experienced non-fatal strangulation. Next slide. So in saying that, with the non-fatal strangulation, a part of our screen is asking that question, asking about, has your partner ever used their body or any other object to forcibly strangle or choke you? And if they say yes, we ask them what kind of symptoms did they have? Was it difficulty swallowing? Was it neck tenderness, voice changes, loss of bowel or bladder, loss of memory, loss of consciousness? And we partnered with our physicians in the ED to develop some guidelines for radiological intervention if they meet certain screening points. But what we've also learned is that non-fatal strangulation is a lethality predictor. And when we have the patient, when we ask the patient that question and they answer positively, we let them know that we are really concerned for your safety at home, because as someone who has experienced non-fatal strangulation, you are 800 times more likely to become a victim of homicide. Now I say that, and we say it in a very gentle way, but we want to give that patient the information that they need to make an educated decision about what they want to do. Next slide. So we also participate in Tarrant County. We have an adult fatality review team, and we meet on a regular basis. And in 2019, there were 8 deaths. And since COVID has hit in 2020, we have 17. And those deaths began the same month that the lockdown started. This adult fatality review team focuses on intimate partner violence. And as you can see on that graph there, in the 8 deaths that we had last year, all but one relationship had ended before the homicide. So only one person was currently living with their abuser when the death occurred. Everyone else had left. And there's a whole nother talk on why don't they just leave. So I'm not going to go into that, but I wanted to give you that information. Of all of those 8 deaths in 2019, 4 of the victims died by strangulation, 3 by firearm, and 1 from a traumatic head injury. So this year, as I said, to date, there are 17 intimate partner violence related deaths or related fatalities. So what this is telling me is that we have a great opportunity as healthcare providers, as nurses working in different organizations across the system, that we have this obligation to screen for intimate partner violence and for human trafficking or potential human trafficking. Next slide. This gives us an opportunity because organizational change that we have done at JPS, it was not, as Jessica said, it wasn't an easy job. It was hard, but we can do hard. So organizational change can be difficult, but based on the findings that we have seen this past year and a half and almost 2 years at JPS, it is well worth it because we've had 100% increase in our referrals to our Family Justice Center as well as to our sheltering organizations. And what we've also increased is our multidisciplinary partnerships in prevention, including the Fort Worth Crime Victims Units, our sheltering organizations, our DA's office, our One Safe Place, which is our Family Justice Center, because it isn't only possible for success with just one organization, but when you partner with multiple organizations, you have a really increased opportunity to provide the resources that these folks need, and it takes a village. And that's my favorite quote up there, that we did the best until we knew better, and now when we know better, we can do better. So that's it. I had my little short update there.
Thank you, Mary Ann. Sally, do we have any questions in the chat?
No, we don't have any questions yet.
Okay.
Well, one of the questions that we get is, what screening tool do you use? Well, we use the HITS tool, which stands for hurt, insult, threaten, and scream. And what we did learn over the course of time was that the nurses did not like to ask those questions in that order. And it is a validated screening tool, and we got permission from the author, Dr. Sharon, of this tool to change the order so that initially they ask, how often does your partner insult or talk down to you? And ending with the physical question of how often does your partner physically hurt you? And that also helped to increase the compliance of screening in our organization.
Mary Ann, I would be curious to know if you guys only implemented this in the ED or if you also implemented it in like high touch areas like labor and delivery, antepartum, postpartum.
Yeah, that's a great question. Yes, we started in the ED, and then we also even hit a couple of our community clinics. And yes, we are in our labor and delivery area. We're in OB triage. We're in the women's clinics, and as well as urgent care. And those are the areas that have the highest findings, urgent care and the emergency department. Our women's clinic is doing a fantastic job, and they actually use this screening as a part of the grant requirements for the Texas Healthy Women for reimbursement. So we got great buy-in there.
Thank you.
You're welcome.
Sally?
No questions at this point.
Well, I appreciate you guys letting me have this opportunity to update from last year's presentation. And I would encourage you to look at your organization and how it is that you're screening. We didn't even realize exactly how we were missing so many screens until we took a look at the data. And so you really have to take a look at that to determine what your compliance level is.
Very good. Thank you so much, Mary Ann.
You're welcome.
Okay, next up we are going to start our panel. So I'm going to start out by introducing Emily Cross. Emily Cross became a nurse to make a difference in the lives of others and in healthcare. Emergency and trauma nursing are her chosen specialties because she wants to shine a light, offer hope and joy in some of the most difficult situations for patients. Throughout her nursing career, she has enhanced her skills in triage, critical thinking, charge nursing, clinical education, research, implementation of evidence-based nursing practices, conflict resolution, communication, performance improvement, problem resolution, and the coordination of care across the continuum. Advocating for patient rights is one of her most treasured nursing responsibilities, and it's her passion. She currently serves as the project champion of the Martha Project at Texas Health Presbyterian Dallas, which comprises a multidisciplinary team with the focus of managing and responding to harm, trafficking, and abuse across the lifespan. Emily?
Thank you so much for that, Candace. It is an absolute honor to be on this panel today with so many amazing nurses who are doing incredible work. Next slide, please. So just a bit about what I do at Texas Health Dallas. I am a trauma nurse clinician, and so I respond to trauma activations for initial resuscitation. I attend daily multidisciplinary rounds. I monitor care and outcomes to ensure appropriate care is rendered. I assist in obtaining PI measures. We screen our patients as well for alcohol abuse and acute stress related to the hospitalization so that we can make sure they get appropriate referrals, especially with the acute stress, seeing if there's a link to the PTSD later for the patients. We provide patient education, abstract data, and then one of my favorite roles is fill the gaps for patients throughout the care continuum. Next slide, please. So the Martha Project. This project is dedicated to the life of Martha Kate Wyant, who is an unfortunate victim of intimate partner violence who lost her life. I would like to have a couple seconds of silence to honor her life, as well as all the victims still currently suffering. This project stands for Managing and Responding to Trafficking, Harm, and Abuse. Our focus is on the care of vulnerable populations across the lifespan. We're looking into how abuse and harm affects every single individual. It's a big picture project, looking into what is creating exploitation and vulnerable situations for harm and abuse and trafficking. There's a lot of great information out there, and we are yielding information from them as well. Within trafficking, particularly, we're concerned in viewing all angles. We're looking into the angles of victims as well as buyers and traffickers. We want to understand for this project how and why is there a demand? Why do people end up in criminal lifestyles? And we're interested in seeing, is there a way to screen those individuals as well? Our thoughts is if we could offer rehabilitative resources, not only could we help one victim, but we could help and hopefully prevent future victims from ever being informed. We are relatively new to the sex trafficking information here at Texas Health Dallas, and as previously mentioned, but this is what we've done so far. We've done a lit review, which is ongoing. We use the gap analysis from the American College of Surgeons TQIP 2020 Best Practice Guidelines. That was mentioned earlier, a really fine document. You can go online to the website, download it, and it has a wealth of information in there on best practices across the care continuum. We're looking into what is the best screening tool to use and potentially development of one. We have our task force that development is currently underway, and we are recruiting stakeholders across the entire care continuum from pastoral care to case management, as well as our inpatient side. Definite integration with EMR. One of my dreams would be to see some of the red flags and the signs and symptoms listed in the medical record so that the nurses, will have that information available. We have collaborated with another THR facility in the system. Susan Bloom is a point person in the ED there who has done a fantastic job with an evidence-based practice project and is currently screening and offering resources to victims there with some pretty good outcomes. Next slide, please. So what have we learned so far, just as we are in the beginning stages of the planning and preparation before we move to the action stage, is what has been repeated previously is trauma-informed care is really the goldmine here as far as educating staff and giving that empowerment and that safety piece, moving it beyond ideals and theories into actual practice. It's also important in our education to have information provided about how the brain works with trauma. This triune brain of a reptilian, mammalian, and frontal lobe is important in assessing the patients because it helps us understand like what part of that are they in when we're trying to assess them. I think of patients that come in that are some of our trauma patients that come in that are agitated and combative. What part of the brain are they accessing right now when we're trying to help them? It's important in training as well to provide information on PTSD and how it affects the body, so that we have that trauma-informed care while we're screening them. As previously stated from healtrafficking.org, the goal is not to rescue the person, but to help them where they're at and develop a relationship with them. Most of these individuals are harmed in relationships, so it takes time to help them, for them to want help just because of how long that's been going on in their lives. This is a very difficult situation for healthcare professionals, as we love to help and fix. When I saw the red flags a year ago, I became informed on sex trafficking and the intersection of healthcare and realized the gaps. And it is really hard to see victims and not be able to rescue them. But hope is a very powerful thing. I love gardening, and so just planting seeds that one day may flourish is an incredible thing. I think of trauma-informed care as truly looking past a person's behavior, substance abuse, any diagnosis, or whatever the barriers may be, and seeing the person. There's power there. To be seen is to not be alone, which can bring freedom. With education, having the protocol at the same time of teaching the red flags is important, because it's one thing to see the red flags, but to have a plan in place, the staff is wanting to know how to help. What do we do? What is the best thing to do? Self-care and resiliency is one lesson that we've learned so far. As nurses start seeing these cases, it is hard to see, it's hard to hear these stories, in addition to the fact that COVID has hit this year, and then we're going into the flu season. So in training, linking the organization's self-care resources and resiliency for staff is important. Another lesson is implicit bias. This was presented to me by Kaylee Vander Tulip. She is our research coordinator here at Texas Health Dallas, and it was put on by Harvard. You can go on their website and take the implicit association test, and it measures a person's attitudes and beliefs that people may be unwilling or even unable to report. The key take home is being willing to challenge our assumptions, as they can become barriers to help the victims that so desperately need help. Collaboration is paramount. I am interested in talking to anyone who wants to talk or share on anything that you have done or we have done, and working together, we can really accomplish the most good. And then as far as effects of COVID at our organization, within the trauma population itself, we did see a decline in our trauma volume from March to May, and then in June and July, we had some of the busiest months on record, and then it's kind of tapered back off going into the fall. We are noticing more trafficking victims. We're unsure if that's because we're now aware of it or if it's a true indication of incline, as we have not been previously measuring the victims and tracking them. Personally, myself, I've seen between 10 to 20 victims in the past year, and I've had one positive result with a patient accepting resources and placement. And then just a side note, one of our paramedics that works in the emergency department said that her name is Carrie, and she does training for paramedics as well, and that they are starting to think of adding torture in their training to paramedics in colleges, so that when patients come in and they're unresponsive, we tend to think mostly of the physical components that could cause that and the abuse that is linked to the physical trauma that we see. Sonia Sims is our SANE program manager, and I did have a little bit of an update from our SANE program for this piece. Overall, she said that most of the consults that she saw came in September, with 32 consults, averaging one a day. She has noted an increase in exams performed in the LGBT community, mainly transgender individuals, and then an increase in the brutality of cases. She shared an article with me by the Indian Journal of Psychiatry, and it is called Children on the Brink, Risks for Child Protection, Sexual Abuse, and Related Mental Health Problems in the COVID-19 Pandemic. This article confirmed that child abuse and neglect is up by 20 to 40% in the US, UK, France, and Australia, and that it's not just a geographical disaster, it has infected vulnerable populations throughout the world, which are at the highest risk, particularly there in India for the article, that children that are increased risk for child labor, child marriage, and sex trafficking. And with that, I will yield my time to the rest of the panel. Thank you so much for this incredible opportunity to speak today on the Martha Project and sex trafficking.
Thank you, Emily. Up next, we are going to listen to Jay Subramanian speak. She, was born and raised in India. She came to the United States of America in 2006. She started as a volunteer at Methodist Dallas Medical Center in 2008 and was interested in giving back to the community. A short time later, she was recruited into their nursing program with El Centro College and graduated with an associate's degree in 2014. She is proud to call herself a Methodist graduate. Education is very important to her, and she loves learning and is currently working on her Master's of Science in Forensic Nursing. She has been an emergency department registered nurse at Methodist Dallas since June 2014 and a sexual assault nurse examiner since 2016. Her goal is to be able to serve the community by helping patients who are underserved and have been victims of abuse. Jay?
Yes, I'm here. Thank you. So I don't know why I'm nervous because there's not even a video. Anyways, though, I'm coughing today. I don't have COVID. It's just cold and spicy food. But I want to tell, okay, so next slide, I guess. Okay, well, okay, one more next slide. Okay, thank you. So, yes, I'm very proud to call myself as a Methodist graduate. Methodist Dallas has raised me to be a nurse. And somewhere I knew that I had to be in the emergency department, serving the vulnerable population that we do and we see every day. Next slide. Okay, so I'm going to expand a little bit on the pandemic effect. So I'm not only the coordinator, I'm also very actively on call and I perform exams on a regular basis. Excuse me. Sorry. So we have sexual and physical violence, which is exacerbated during the early stages of pandemic. So from March to May, just like Emily said, our volume was a little low, but the brutality had increased. But I think it was like June or July, I think we had more patients coming in. I think the stay-at-home policies, introducing job loss, lack of social support, brutality increasing. I kept a tab on it, especially with the strangulation and visible signs of it, and this physical trauma along with sexual assault cases. Trafficking cases was also on the decrease between March and I would say about April, May. But after that, I've seen several patients. I only know because my nurses would call me in and say that there's something off about this because we educate our nurses in the emergency department to see signs. And like Jessica Peck was saying, you know, staying in the lane is so important. If you're not a forensic nurse, we try not to intrude the patient with information. But when I go, or one of the same nurses go and assess the patient, and if they become positive for the screening, we actually offer them a lipstick with rescue information inside of it, so the trafficker would not see any kind of return resources on that. But I also have had patients who came in who actually chose to go back to the traffickers, which really perplexed me. But I see why that happened, because the shelter she was staying in had no financial support, and she did not have any other choice but to return. She came in with extreme physical assault. She was admitted to a trauma floor for some time. And also we have the pandemic is also, I think, creating a new class of victims, especially women who cannot afford to pay rent. So the last couple of cases that I've done have been where they saw Craigslist ad on room shares and the landlords sexually assault the woman or the roommate or the man, I mean, really the victim in exchange for a placement. So one of my sexual assault patients actually saw the Craigslist ad. I just had another one come in, another victim come in about 4 days ago with severe cases of strangulation, and her CT scanning was positive for that. So the brutality has definitely increased. Number of sexual assault cases has decreased in the initial stages. Now it's picking up back. We have cases also, drug facilitated cases that has been on the increase. Next slide, please. Thank you. And I would just like to talk about a little bit of the dashboard of Methodist, just so we can see what happened. And these cases, the majority of the cases, this is from year to the date, and the majority of cases are coming after June. We did a 95 exams, which Methodist is really fairly a young, sane program, and I absolutely love my job. What I do, we have a team of 8 nurses, including me, and we are trying to expand the program where we are able to have more nurses to have more coverage. We are at this time providing 24/7 coverage. We did 95 exams, out of which 88 were females, and 7 males. So about 82 of our cases came from the Dallas city limits. We did have cases come from Mexico and London. Our age group mostly belonged to the age between 18 and 29. The reason why I put 49 patients reporting physical abuse with sexual assault is because all those patients actually reported physical abuse with sexual assault after the month of July. And we have 42 patients reporting strangulation, out of which 19 patients had visible signs. Petechiae, vascular congestion, incontinence reported, all of those cases. And we have, we have had about 54 reported non-stranger assault, and 41 were strangers. Of course, we all know that most of the time sexual abuse and the predators are known to the family. We've had, sadly, nursing home patients come in, and caregivers being the perpetrators. We do have a very special program with HIV prophylaxis where we are able to refill it at no cost. So we refill that for 36 of our victims, and 45 patients reported intimate partner violence and increased severity of abuse. These 45 patients are out of the 95. So you can see actually the number, which is like probably close home. You're exposed to the perpetrator through the day, so increased chances of abuse. And so we definitely see a spike, and the relation between the pandemic, along with human trafficking, intimate partner violence, sexual assault, everything is hand in hand with that. So we definitely see a raise on that now. But in the initial stages, it was low for us. Thank you. Thank you for having me here. It's really, really a great opportunity to be connected with DFW Hospital Council.
Thank you, Jay. Next up, we're going to hear from Connie Housley. She is the coordinator of forensic nursing at John Peter Smith Hospital in Fort Worth, Texas. She received her Bachelor's of Science degree in nursing at the University of Texas, Arlington in 2000. She then began her nursing career as a staff nurse in the emergency department at JPS Health Network, a level 1 trauma center. She is certified in BLS, ACLS, PALS, TNCC, EMPC, and is a certified SANE nurse. In 2004, Connie became an OAG certified sexual assault nurse examiner, and in 2005 started practicing as a SANE in the emergency department at JPS. As a SANE, she provides comprehensive care for victims of sexual assault and domestic violence, including detailed medical forensic exams. Connie has maintained that certification, and in 2008 became the coordinator of the program at JPS, which provides services to over 9 counties in North Texas. In this role, she oversees and manages the program and its staff of 9 sexual assault nurses. She has been the recipient of the Gold Stethoscope Award. From 2012 until 2015, in addition to her duties as a SANE and SANE program coordinator, she also assumed the role of grant site coordinator for the HIV screening program, where she was responsible for overseeing the DSHS contracts for HIV screening in the emergency department. Connie also represents the JPS Emergency Department on the Peer Review Committee and has assisted with quality assurance on the Stroke Committee. In 2015, the JPS SANE program won the Mitch Poe Award from the Tarrant County Sexual Abuse Council, which honors professionals who distinguish themselves as passionate defenders of victims of sexual abuse. Connie has testified in court numerous times as an expert witness in the field of sexual assault and domestic abuse. Connie continues to provide direction over the program and has provided countless hours of patient care to victims. She also provides education to other nurses on the care of the abused patients, as well as many disciplines in the community on issues related to sexual abuse and domestic violence. She is married with 3 grown children and 1 grandson and resides just outside the city of Fort Worth. And might I remind everyone that as you guys listen to these presentations, please feel free to enter in questions into the chat. Connie?
I'm here. Thank you for that warm welcome. This is a little bit of a different platform for me. I've never done a webinar where I can't see my people. But I am very glad to be here. I'm very glad that this education is offered to other nurses in the area. It's a very important topic. And again, as others have said, a lot of this information can be triggering. And so we do want to be mindful for those that may need to step away or just understand that this is definitely a difficult subject, but one that's really important and that we need to recognize in our institutions. Next slide. Mary Ann had already shown this, but very proud of the facility that we work for at JPS Health. We are a county hospital, and we have about 121,000 emergency room visits every year. Next slide. So a little bit about our program here at JPS. We've been providing medical forensic exams for sexual assault patients since probably forever, but to date, in around 1980s, our physicians and OB residents were performing those exams. And as the field of forensic nursing became more prevalent in the 90s, nurses started taking on that role. I mean, again, I started this in 2004 and have been practicing ever since, and it's definitely evolved over the years. At our program here, we see about 600 patients every year for sexual assault, excuse me, and we treat the adolescent and the adult patients. So any female who has secondary sexual characteristics or has started menses is a patient that is appropriate by our team. We partner very closely with Cook Children's, and we work with them for referrals or vice versa, and just communicating how we can best meet our community's needs. We are part of the Tarrant County Sexual Assault Response Team, in which we provide a coordinated response, community response to sexual assault. We serve 9 counties in this area because there are no other programs necessarily in some of the outlying communities. We provide medical forensic exams, which are either referred to us, police may bring them, or they could just walk into the emergency department. We also are consulted by a lot of different areas of the hospital where it comes to abuse or sexual assault, and so we take our services maybe to an inpatient unit, or, you know, as mentioned before, I think we have a huge opportunity in our psychiatric patients to at least recognize that those are potential victims of either domestic violence or sexual abuse, and where's that trauma really coming from. And we'll talk about that a little bit more later. We have 9 nurses on our team right now, and we have 2 in training. Training's looking a little bit different these days, as we've never had virtual training as far as the didactic part, but we'll be doing the clinical training here ourselves. So I'm anxious to find out how that's gonna work. Our future plans actually is, you know, we work really closely with Mary Ann and her team, and we really know that there's a need to be providing exams for our domestic violence patients, for patients who are strangulation and don't have that element of a sexual assault at that time. And so we're really seriously looking into how we can better service this population by providing that service to them as well. And so hopefully that will be something that we see very soon. Next slide. So the purpose of my talk today was to really focus in on how we've been affected by the pandemic. And I don't think there's a person in this world that hasn't been affected by it somehow. But in the healthcare arena, pre-COVID, like I said, we see about 600 patients every year for sexual assault. In the first part of 2020, that remained true. We were still seeing about, on average, the same amount of patients. What had changed was probably about mid-March, in all hospitals, I'm sure, across the country, we had to change the way that we were going to provide services. And at that time, we moved our SANE suite to a different area of the emergency department. We wanted to make sure that anybody that came into the ER didn't have that fear of being in the hot zone. And so we moved our services. We tried to get the word out with our community partners that we were still here. We were still providing 24/7 care. It might look a little differently as far as where we were located, but we were still here to serve. In April, everything changed. Our numbers dropped by 50%. And so we weren't seeing those victims. And it was concerning for us because we knew that a pandemic did not cure the abuse that was going on in our community, but we feared that patients weren't coming in because they were not feeling comfortable about visiting the hospital when every news arena and everyone was telling them to stay away unless you had to. And so that was a little concerning for us. What changed was in May, and I saw a significant difference in the number of patients that came in, but not only a significant difference in the number, but was in the violence. It became very violent, physical violence. And we saw about a 233% increase in strangulation cases than we had at the same time last year. And obviously that was very concerning. Where was this going? What was the rest of the year going to look like? In June, July, August, things kind of settled a little bit, but still on the increase. But it was May that we really saw the biggest difference. And again, what has changed? The setting. You know, we changed where we were located. Everyone was wearing masks. People were fearful of the emergency department. But on a bigger note, they were also in fear of being at home with that abuser and not being able to seek services. Before COVID, we had an advocate present at every exam as a resource person who could be there for their emotional needs. Once COVID hit in March, the advocates, because they're volunteers and we didn't want to have them at risk for their own health and their own families, they weren't presenting to the hospital. They were there, but they were doing it a little differently. So we were looking at different ways to connect them with the services, and a lot of that was virtual. And so that looked a little bit different. And reporting, you know, obviously we said earlier that we were in fear that people weren't going to report this now. And as everybody has said on this panel, and as we know, because this is the work that we do, it's increasing. This is from an excerpt from Safe Haven, that our intimate partner homicides had been declining in Tarrant County for the last 4 years. But in 2020, we've already had the worst number on record. And that's terrifying. Next slide. So in our community resources, what has the impact been on them? Well, statistically, they ran about 60 calls a day to the local Safe Haven domestic violence shelter, and then it dropped significantly in March. Again, I think because these victims were at home with the abuser and unable to use the phone or seek out those resources. But just as everyone else has said, that things started to increase. Once April hit, you saw a little bit more, and then when things opened up in Tarrant County, and we were able to start visiting restaurants and getting out a little bit more, we've seen a 30% increase in calls to our domestic violence shelter. And then shelters, they were operating at full capacity because they were having to maintain safe distancing and find unique ways to house these people who actually were in need of their shelter assistance. And again, this counseling now has become something that I think we're all getting used to, is doing things virtually. But what I have found out from our partner, the Tarrant County Women's Center, is that they're getting more compliance with counseling because it's virtual. I think it might be easily accessible for some, that they don't have to find transportation to get to the counseling center, and they have access through the internet or whatever means that is. Next slide. So as leaders in healthcare, we're all educators, but what can we do? I think it's really important that we are promoting the importance of the screening for abuse. Like Marianne said, last year we screened about 85,000 people of the 121,000 that we saw in the emergency department. I think that's phenomenal. I think, you know, we know statistically that 14% of all ER visits are domestic violence victims, whether that's for this visit or in their history. We also know that they visit the emergency department multiple times. They also don't necessarily come in for an actual encounter of abuse that time. Maybe they're having psychiatric problems, anxiety, different things in that nature, or maybe things that don't even relate to that, as far as, you know, continual sexual, like stomach aches or different other medical problems that we're not relating to the abuse. So it's really important that we're mindful of some of those risk factors in our youth, our psych, and our elderly, especially our youth. We're seeing a lot of psychiatric kids who are coming in for whether that's cutting or overdosing or risky behaviors that we don't want to necessarily write off as being just a kid that has, you know, these unfortunate circumstances. I think we really need to work together to understand that there could be some element of abuse in their past or their present. And so, again, Marianne and I are working on, with our psychiatric department, in delving into this a little bit closer so that we can help this population. We want to ensure that staff knows what are reportable offenses and have well-established protocols, including safety plans. There's documentation obligations for the nurse, and you can find those in Chapter 91.01 of the Texas Family Code. It's important to note that we have to respect the privacy and decisions of our patients. Not everybody's ready to report at the time that they may enter our hospitals. And so we have to understand what their reasons are, and we don't live their life every day. And so, you know, we just have to be there to understand that we have resources. Some may be financial concerns that they have, but there are resources available to them to help them through all of that. And we need to make sure that they have information and knowledge on how to get away if that's, if and when they choose to do that. So our recommendations obviously are to make resources and discharge instructions easily and readily available to your staff, and to listen and to believe them. There's a lot of bias surrounding sexual assault and domestic violence, and we need to understand that we may not understand why they stay, but we need to listen and just provide that care that we can in their time of need. Next slide. I guess that's it. If you have any questions, my contact information is on the first slide, and I'd be happy to answer any questions that you might have.
Very good. Thank you so much, Connie. Sally, do we have any questions in the chat?
No questions at this point. Oh, here, sorry, we got one that just came up. Are there other screening tools to use besides the HIT screening?
Yeah, this is Mary Ann. There's quite a few. We did a literature analysis and looked into different validated screening tool. And there you can Google that and grab a bunch of those. We chose the HITS because it is very simple. It's easy to remember, and it's 4 questions. And as anyone knows, you know, we have so many screenings as nurses that we have to do. We wanted to find one that was validated and quick, to the point. So that's why we chose the HITS tool. I can't cite a bunch of them off top of my head at this minute, but there are quite a few.
I'm showing no questions at this point, Candace.
Okay, very good. Well, I would like to thank everybody for their participation. Thank you so much to our speakers and our panelists. And Sally, I'll let you close with remarks.
Okay. Well, thanks everyone. We would like to thank the speakers as well, and our panel members in sharing their information about their programs. We here, as a reminder, the last slide here, if you've got any questions or would like to see the presentations or the recording or anything, again, go to our website, dfwhcfoundation.org /educational events. And you'll find everything there, the recordings, the presentations, and then you will also find the link for the CE evaluation that'll be posted on October 29th after our final presentation. And just a reminder, you'll need to have that completed by November the 13th, and then about a week or two after that, you will get your certificate for CNE. And you will also get a link to complete the form for the Human Trafficking Credit Hour for House Bill 2059. And then just FYI, credit is not available for viewing the recordings. So that's essentially what we've got in regards to getting the evaluation and the CNE. Again, further information is on this website that's listed here. For the event today. And with that, I think we've got everything. That's what we had to cover for today. So again, our thank you to the speakers and our panel members and our moderator. We really appreciate your sharing your information today. So with that, we'll conclude the session. So thank you, everyone. Bye.
Thank you.
Thanks.
Thank you.
Thank you.